Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. On this week's video, we're exploring part 2 of our 4-part series related to gait disturbance and assistive devices. And today I want to talk to you about the gait cycle and what constitutes normal gait. And then once we have a good understanding of normal gait, I want to consider some various examples of pathologic or abnormal gait. So we'll go over a brief description of some of the subphases of the gait cycle, and then we'll go into some of the named gait signs, including the gait signs that are specifically described in the AMA guides, including Antalgic Gait and Trendelenburg Gait, as well as several others. So before we begin today's presentation, I hope you had an opportunity to review last week's presentation where we talked about part 1, which I entitled the necessity of doing a complete and thorough analysis of the gait in those cases wherein you provide for permanent impairment due to station and gait disorder in Chapter 13 or gait derangement in Chapter 17. So if you've not had a chance to review that video, I include a link for that video above. And this 4-part series that we're doing this month on gait and gait disturbances is a complete course on the AMA guides and the AMA guides descriptions of gait derangements in both Chapter 13 and Chapter 17. So this is going to be a valuable resource that you can refer to again and again and again over the course of the months and years as you encounter those cases that could possibly qualify for permanent impairment due to gait derangement. And one last comment before we get into today's discussion, and I'll probably reiterate this point another dozen times by the time we complete this series. And I can't emphasize this point enough. And I believe that I'm a lone pioneer in the QME industry in this point, because as far as I know, this idea, this concept, and this material is not being discussed or talked about anywhere else. And that's really not a surprise. But the point I want to make to you is that it's absolutely necessary that you do an excellent evaluation of gait on those cases for which you provide permanent impairment for gait and gait disturbance. And really, that makes all the sense in the world when you think about it, because you would not provide permanent impairment for, say, a spinal impairment without an excellent examination and without excellent objective findings to substantiate your conclusion for permanent impairment. Well, the same situation exists as regards to gait disturbance and permanent impairment. However, I find that there's an exception, an apparent exception with providing for permanent impairment due to gait disturbance, because many doctors do not provide any type of an analysis of the gait or any type of substantiation of their opinion or conclusion for permanent impairment related to gait. And in my opinion, that is a gaping and a glaring omission. And the opinion or conclusion on permanent impairment is simply not going to be upheld because it does not qualify as substantial medical evidence in the absence of an adequate exam. So I believe that I'm a pioneer on this topic, and I'm going to stick to my story and insist and encourage you to adopt a formal gait analysis into your routine procedure. Now, on our very next video, which is coming out next week, I'm going to go through in great detail the process involved with doing the formal gait analysis in the face-to-face evaluation with your injured worker. Before we get to that, however, I want to get into today's material and just lay some foundation for what it is that we're going to assess when we get in the face-to-face evaluation with an injured worker. And when it comes time to do our formal gait analysis, what are some of the considerations and what are some of the things that we should be looking for in order to provide for permanent impairment due to gait derangement. So I want to begin today's material by talking to you about some of the details involved with the gait cycle. And we're going to keep this relatively simple, probably only to the depth that's required by the AMA guides. So let's begin with a discussion of the gait cycle. We'll then talk about normal versus pathologic gait, and we'll conclude with a video taping presentation of the named gait signs, wherein we try our very best to depict some of the named gait signs that you would commonly encounter in your QME evaluations. Okay, so with that as our introduction, let's now begin. So here we have a diagram of the typical gait cycle, and what I want to do is I want to simplify this diagram for you, and we're going to approach the gait cycle from a layman's perspective, only to the depth as required by the AMA guides. Now the AMA guides are interesting. They don't go into any detail at all regarding the gait cycle, but they do provide for some basic permanent impairments that will be easily understood if we can get our heads around some of the basic components of the normal gait cycle. So in this diagram here, I want to draw your attention to a couple things. Number one here, we're looking at the right lower extremity at the initiation. This is an arbitrary initiation of the gait cycle with what we refer to as heel strike. Heel strike. Now, heel strike initiates the stance phase of gait. So what we're going to look at is we're going to look at the stance phase of gait as relates to the right lower extremity. And then we'll move into the next phase of gait, which is the swing phase of gait, again, focusing on the right lower extremity. So one complete gait cycle begins with right heel strike and concludes again with right heel strike. So one complete cycle involves all of the motions of the right lower extremity from the initiation of stance, all the way through stance, through swing phase, and all the way back to the initiation of the next cycle, beginning again with stance phase. So it's interesting, the stance phase of gait accounts for 60% of the time of the entire gait cycle. The swing phase of gait accounts for only 40% of the time of the entire gait cycle. So stance phase of gait, let's review some of these phases of the stance phase of gait, tracing the movements of the right lower extremity all the way from the initiation of stance at heel strike all the way through the conclusion of stance phase with what's referred to as toe off or pre-swing phase, all of which are contained within the stance phase of gait. For the purposes of this diagram, it's important that you remember that the stance phase of gait accounts for a greater proportion of time of the overall gait cycle. It's a 60-40 relationship. And this is important to understand because later on when we get into the AMA guides, particularly in Chapter 17, the AMA guides provide for permanent impairment due to what they refer to as a shortening of the stance phase of gait, a shortened stance phase. So a shortened stance phase is when the stance phase of gait no longer comprises approximately 60 to 65% of the overall time. The stance phase starts to approach, for example, 50-50, or perhaps 45-55, or perhaps a reversal at 40% stance and 60% phase. And I want you to think about your own life if you've ever had an injured lower extremity. Say perhaps you may have had a badly sprained ankle. you'll remember that when you walk on that painful ankle, you walk with what you refer to as a limp. Well, what is a limp? A limp is a shortening of the stance phase of gait. And depending upon how much pain you're actually having with that lower extremity will determine how shortened the stance phase becomes. And I can remember a time in my own life when I had a badly sprained ankle, and I remember being able to just bear weight on that ankle for only just moments, just enough time to be able to swing my contralateral leg around to be able to bear weight on the other leg. So that badly sprained ankle that I had served only as a momentary peg to allow transfer of weight to the other unaffected lower extremity. In that case, the gait cycle resembled more like 20% stance and 80% swing. But for our purposes, important to remember that should be approximately a 60 to 65% of the time occupied by the stance phase of gait, and 35 to 40% occupied by the swing phase of gait. Okay, so let's dissect each of these phases down a little bit more. So here we go. This is not the best or clearest diagram, but it clearly does depict several of the sub-phases of the stance phase of gait and several of the sub-phases of the swing phase of gait. And again, this diagram indicates that stance comprises 60% of the time and swing phase comprises approximately 40% of the time. So again, we see here that the gait cycle begins with the heel strike of the right lower extremity and concludes with the second heel strike of the right lower extremity, which would then initiate the very next cycle. So let's break down some of these sub-phases of either the stance phase or the swing phases of the gait. Okay, so with the stance phase of gait, we have 5 basic sub-phases, which begin with the initial contact at heel strike. So here we have the right lower extremity making its first momentary contact with the ground. That's referred to as initial contact. Then as the weight of the upper body then moves over the extended right lower extremity, we refer to that phase as the loading response phase. This is when the right lower extremity is beginning to accept weight bearing of the entirety of the body weight. Now, one of the key phases to understand within the stance phase of gait is referred to as the mid-stance phase of gait. Now, at the mid-stance phase of gait, the lower extremity and the torso are in linear alignment, and the right lower extremity is now bearing the entirety of the full body weight. And it's referred to as the mid-stance phase of gait because it occurs exactly at the midway point throughout the time passage of the stance phase of gait. So this occurs approximately 30% of the time of the entirety of the gait cycle. It occurs at the 50% point of the stance phase of gait. Then as the body weight continues forward over the extended right lower extremity, we start to see the heel start to elevate from the ground as the ankle goes into dorsiflexion. Now, some textbooks refer to this as push-off. This particular diagram refers to this as the terminal stance phase of gait. Some references refer to this as push-off. Some references refer to this as toe-off. In this particular example, this is referred to as the terminal stance, which then initiates the final phase of the stance phase of gait, known as pre-swing. So in the pre-swing phase of gait, other textbooks refer to this as final toe-off, because here we see the metatarsal phalangeal joints in extension and the toe now just getting ready to leave the ground and to terminate the weight-bearing phase of the stance phase of gait. So the pre-swing phase of gait initiates the swing phase of gait. Now the swing phase of gait itself has three basic subphases. And by the way, these are just basic subphases. The gait itself, of course, has been analyzed down to the millisecond. And these are just three gross phases throughout the swing phase. So the swing phase begins with the initial swing. And with the initial swing, we start to see the acceleration of the right lower extremity starting to accelerate forward to approach the next gait cycle, where the right lower extremity would contact the ground at heel strike again. So it begins by an acceleration of the right lower extremity at initial swing. The right lower extremity passes the midline of the body and begins to decelerate through mid-swing. And then finally, at terminal swing, the right lower extremity approaches a position of heel contact, which would then begin the next cycle of the gait cycle, or a second cycle of gait. Now here's another diagram that shows basically the same concept, and I simply present it here because it looks like a slightly better diagram or a slightly different diagram. Again, we have the gait cycle beginning with initial contact, progressing through the loading response phase into the mid-stance phase of gait. And at the mid-stance phase of gait, you can see there, if we drew a line directly down the center of these two images here, we would have the exact mid-stance phase of gait. Neither one of these is exact mid-stance, because here we see the right lower extremity somewhat anterior to the weight of the body. Here we see the right lower extremity somewhat posterior to the center of mass of the body. So exact mid-stance phase of gait would be somewhere in between those. We then progress to terminal stance and then pre-swing, which begins the initial swing, where the right lower extremity accelerates forward, through to mid-swing, which begins the deceleration then of the right lower extremity, and then into the terminal swing phase of gait, where we approach heel strike of the next gait cycle. So for our purposes and for the AMA guides, we're simply going to consider that the gait cycle can be broken down into two components, the stance phase and the swing phase. And the stance phase comprises approximately 60 to 65% of the entirety of the cycle, whereas the swing phase comprises only 35 to 40% of the cycle. And these are going to be interesting facts to remember as we go through our gait analysis and our gait observation. It provides the basis for us to establish what we would define as normal gait and what we would define as pathologic gait. So let's define both of those. So what we're going to do for the remainder of this section of the program is we're going to compare and contrast normal gait with pathologic gait by comparing normal gait with pathologic gait at each of the subphases of the stance phase of gait. So we'll consider normal gait and what happens at heel strike from both the lateral and anterior view. And then we'll contrast that with pathologic gait at heel strike from both the lateral and anterior view. And we'll repeat that process for the mid-stance phase of gait, and then also for the toe or push-off phase of gait. Okay? So let's begin now. Let's consider normal gait, focusing on the right lower extremity, beginning first with a lateral view. Okay, so we're now considering heel strike of the right lower extremity from a lateral view. And I want you to picture this in your mind You're standing to the right side of the examinee, and as the examinee walks down a long parking lot, you are walking alongside of them, focusing on their right lower extremity, considering what types of findings are normal findings as the right heel makes initial contact with the ground. Well, normal findings would include the facts that the head and trunk are vertical, the right arm is slightly posterior to the midline of the body with the elbow slightly extended. And this is an important point. So note that as the right lower extremity comes forward, the right upper extremity goes posterior. This is known as reciprocal arm swing. Reciprocal arm swing. And we'll talk a little bit more about reciprocal arm swing when we get into a discussion of canes and assistive devices. Okay, so if the right arm is slightly posterior to the midline of the body, the left arm is slightly anterior to the midline of the body, and this is the component of reciprocal arm swing. The right knee is extended but not locked, and the ankle is in slight plantar flexion, being just released from full dorsiflexion. Okay, so I want you to sort of picture this in your mind, how the right lower extremity would look from the side during normal gait at heel strike. Okay, well, let's contrast that with some examples of pathologic gait, again considering the right lower extremity from the lateral view. Well, some pathologic findings could include the fact that there's forward shifting of the head and the trunk, where the head and the trunk get in front of the center of mass of the body. The knee could be locked in extension or possibly even hyperextension, or alternatively, the knee is flexed and fails to achieve full extension. And I'm reminded of a woman who belongs to the local gym where I work out, and she walks across the foyer of the gym every day that I'm there, and I note that neither of her knees are able to go into full extension. And when I questioned her about this about a year ago, she informed me that she had recently had one knee replaced, and the second knee was pending replacement. And it's interesting, you can notice that she's unable to fully extend her knees. And this is notable both on the stance and swing phases of gait. In addition, you could notice that the foot lands flat on the floor, or even the toes land first on the floor, and the forefoot and toes may slap to the ground. And I'm sure you're aware of what type of gait we're referencing here with this type of finding. So I want you to try and visualize some of these disturbances in gait from the lateral view. And we'll describe more of these findings later when we talk about some of the named gait signs. Okay, let's go back to normal gait at heel strike now, and let's take a look at the anterior view of the body at heel strike. We notice that the head and trunk are vertically aligned. From the front, we notice that the arms swing at an equal and symmetric distance from the body. The pelvis lists slightly inferior on the right side. If it was to list slightly inferior on the left side, that would be considered a pathologic finding. We notice that the right thigh and leg are in vertical alignment with the pelvis, and that the plantar surface of the foot is visible to the observer standing 10 feet away from the examinee. And what would it indicate if we were unable to observe the plantar surface of the foot? Well, that would be consistent with a drop foot. And so drop foot is going to be one of the recurring gait disturbances that are described throughout these examples, and I'm sure you will note those findings as we review those. Okay, well, what are some pathologic findings? From the anterior view at heel strike, we see that the trunk displaces either to the right or to the left. It'd be more common to displace to the right, and that would be, well, I'll just reserve the punchline as to what type of gait that represents until a little bit later. We notice that the right hip is in lateral rotation. Perhaps the right hip is in protective abduction in order to broaden the base of support. And the plantar surface of the foot is not visible, suggestive of perhaps limited or absent dorsiflexion of the ankle. Okay, let's go to mid-stance and focus on the right lower extremity from a lateral view during the mid-stance phase of gait. We notice that the head and trunk are vertical. Both arms are near the midline of the body with the elbows slightly flexed, and that's one of the characteristics of the mid-stance phase of gait, is that both lower extremities and both upper extremities both come to the midline of the body. That's a characteristic finding of the mid-stance phase of gait. We notice that the right knee is in slight flexion and the right ankle is in slight or even neutral dorsiflexion. Now, with a pathologic gait, also at the mid-stance phase of gait, we see that the head and trunk are perhaps shifted either forward or backward of the hip joint, and each one of those would be characteristic of one of the particular named gait signs. The knee could be locked in extension, could be in hyperextension, or in the case of the woman at my gym that I was referring to, it could be in a position of exaggerated flexion. Possibly you may observe the ankle to be in exaggerated dorsiflexion. Okay, let's talk about from the anterior view. What are some findings of the mid-stance phase of gait during heel strike from the anterior view? Well, we see that the head and trunk are vertical with the arms at an equal and symmetric distance from the body. The pelvis lists slightly on the left side. We see that the right hip has slight lateral rotation. Now, in the pathologic gait during the mid-stance phase of gait, from, again, we're talking here about the anterior view, we see that the head and trunk tip to the right and the pelvis tilts upward on the left side, with the right arm away from the body, further away from the body than the left arm. We see that the pelvis has an exaggerated list on the left side, and other possible findings could include an exaggerated outward rotation of the hip and varus or valgus positions of the foot. And it's interesting, if you've seen many examinees or patients in your clinical practice with a drop foot, you'll note that they have this compensatory valgus outward positioning of the foot, which helps to serve to broaden the base of gait and stabilize gait. Now, now moving to the push-off phase of gait. Again, we're at the right lower extremity looking at with a lateral view. We're at the push-off or toe-off phase of gait. We notice that the right arm is now anterior to the midline of the body with the elbow partially flexed. The left arm is slightly posterior to the midline of the body with the elbow extended. And this is, again, another example of reciprocal arm swing. And this brings up an interesting point, which we should take a moment to discuss here. Part of normal gait involves reciprocal arm swing. And so that raises the question, could injuries to the upper extremity qualify for permanent impairment due to gait disturbance? And I'm not going to answer that rhetoric question with either a yes or a no, but I simply leave it to your creativity and your clinical judgment as to the impact of an upper extremity injury on normal gait. And I have, in my own experience, had occasions where I've had examinees who had significant upper extremity injuries that, in my opinion, qualified for gait disturbance due to loss of reciprocal arm swing. And I provided for permanent impairment due to gait disturbance in those cases. So you may consider that in your own practice as well. Again, during the push-off phase of gait from a lateral view, we see that the pelvis has a slight anterior tilt. The right knee is partially flexed, and the ankle is now assuming a position of plantar flexion. Plantar flexion as the heel lifts off of the ground. The toes, however, still in contact with the ground, are in extension at the metatarsal phalangeal joints. And this is interesting. I have an example for you coming up in some of our videos where we demonstrate bona fide examples of gait disturbance. And one of the examinees has ankylosis of the metatarsal phalangeal joints. And it's interesting, we sometimes forget the function of the metatarsal phalangeal joints as they are involved with normal gait. But let me tell you, if you lose extension of the metatarsal phalangeal joints, especially of the great toe, it creates a dramatic gait disturbance by shortening the stance phase of gait. Particularly, it shortens the push-off portion of the stance phase of gait. And I have an excellent video for you coming up here shortly. In the pathologic gait at the push-off phase of gait, again from a lateral view, we see that the arms are at an uneven distance from the midline of the body, and both elbows are flexed. The pelvis has an exaggerated anterior tilt. The right knee could be forcibly extended versus slightly flexed. The ankle plantar flexion may be limited, or the ankle may be in a position of dorsiflexion. And the metatarsal phalangeal joints may be neutral rather than in extension. And as I said, this creates a dramatic shortening of the stance phase of gait that you simply cannot miss. And I have an excellent example of that for you. Okay, let's now consider the swing phase of gait. Again, looking at the swing phase of gait from the lateral view, and then also from the anterior view, comparing normal gait with pathologic gait. So some normal findings during the swing phase of gait would include the facts that the arms are near the midline of the body, pelvis has a very slight anterior tilt, the right hip joint and the knee joint are both slightly flexed, and that's important to allow the leg to come through and clear the ground and accelerate through the swing phase of gait to approach the next gait cycle, beginning with initial contact at heel strike. And then in order for the foot and ankle to further clear the ground, the ankle has to be in slight dorsiflexion. Now, some pathologic findings would include posterior tilting of the pelvis. You could observe that the right hip and right knee flexion are exaggerated, and the forefoot is dropped into plantar flexion, and that the toes drag on the floor. Another example of exaggerated knee flexion involves the examinee who has limited extension of the knee due to degenerative arthritis or perhaps due to knee replacement. And these findings that we're describing here are characteristic of the steppage gait due to L5 radiculopathy or other weakness or dysfunction of the anterior tibialis muscle. So you can visualize this in your mind, and I'm sure you've had examinees in the past who have had drop foot. And you'll recall the exaggerated hip and knee flexion to allow the toes to clear the ground. Now, not all examinees who have drop foot ambulate with excessive hip and knee flexion. Some examinees are quite creative and quite clever as to how they disguise their drop foot. Many examinees you'll find have an outward rotation of the hip and the ankle that allows the toes to clear the ground more laterally rather than in the anterior or sagittal plane. So again, when assessing examinees and using the case of drop foot as an example, this disturbance in gait can be quite subtle as examinees learn to adapt and learn to compensate their gait for these weaknesses, but this can be picked up through observation as a disturbance in the normal swing phase of gait. And the swing phase of gait will either be shortened or lengthened in comparison to the stance phase of gait, and this is something that is readily noticeable if you sharpen your attention and focus your attention on it. Okay, let's take a look at the swing phase of gait from the anterior view. From the anterior view, the head and trunk are vertical. The arms are at an equal distance from the sides of the body. The pelvis has a very slight lift now to the right side. The right hip is in very slight medial rotation, and the right ankle has slight eversion to help the toes clear the ground. In the pathologic finding, or in the pathologic case, we see that the head and trunk lean to the left side. The pelvis is lifted on the right side and drops on the left side. The right hip is abducted, and the leg may be circumducted in an arc. We see that the hip is laterally rotated, and the forefoot is dropped into plantar flexion. So the challenge that I have for you is not to remember all of these findings, but the challenge is to observe gait and simply to sharpen your focus of attention as to any disturbance that creates difficulty with gait, that creates an altered rhythm of the gait, or that creates unusual labor with the gait. Recall the definition from Webster's dictionary is that the gait, normal gait, should be unlabored. And many of these disturbances in gait, whatever they may be, whether it be with a problem due to a problem at the hip, problem at the knee, problem at the foot, a muscular problem, whatever, creates difficulty and extra labor involved with gait. And so this is what I want you to sharpen your attention toward and start to focus on. And good places to observe gait include the mall, at the post office. It seems to me that every time I go to Walmart, because there's a large large population of people visiting the Walmart, I always see examples of gait disturbance at the Walmart. Another thing you can do is simply park your car at a busy supermarket and watch the people come and go from the supermarket, and you will notice people with disturbances of gait. I frequently see it say that gait disturbances are all around us. So it's interesting. It's easy to spot deviations in normal gait once your focus becomes tuned to it. It's harder to identify the cause of the gait disturbance. The first step is to identify that indeed a disturbance exists. And then once you have that established, you can turn your attention and your focus toward identifying the cause of the deviation. And this is something that takes some time and some practice, and frequently takes an extended observation of the examinee. Sometimes we don't have extended observations of the examinee. For example, if you are at the Walmart or you are at the post office, you may have only a limited observation of your prospect, after which the prospect turns a corner or becomes obscured by traffic or other people or what have you. And so identifying the cause of the deviation is more difficult. And in the QME evaluation, this is where you can enlist the help of your examinee to help you identify what is the true cause of the deviation. And sometimes the examinees themselves, they're not entirely clear as to what's the cause of the deviations themselves. But between the two of you, you should be able to identify the true cause of the deviation. And I have an interesting story about that illustrates this point. One time I was going into a supermarket. I was actually visiting my parents, and my father and I were going out for a sandwich. And as we went into the supermarket to get a sandwich, a woman was entering the store in front of us, and she grabbed a shopping cart. And I noted right away that she had a gait disturbance. I couldn't tell exactly what it was, but I noticed that she had what looked to be a shortened stance phase. And this was a very limited observation as she walked in front of us to grab a shopping cart. And so as we got inside the store, I said to her, I said, Miss, I'm a doctor, and I noticed that you are walking funny. I said, I noticed that you have a limp. Are you having pain in your hip? So, in my opinion, based on a brief observation, I speculated that the problem and the cause of her gait disturbance was at her hip. And she was in a good mood, and she was friendly, and she said, no, it's not my hip, it's my knee. And this seemed to be a bit of a surprise to me, but you never know. And as I said, identifying the cause of gait disturbance is sometimes not instantaneous. And so I said to her, oh, well, that's interesting. It looked to me like you were favoring your hip. And she thought about it for just a second, and she said, well, yeah, I guess you're right. My hip has been bothering me. And so it could have just as easily been due to her knee. It could have been due to her hip. It seemed to me it was due to her hip, and she admitted that she had been having pain in the hip. The point is, identifying the cause of the deviation of gait comes second. First order of business is to identify whether or not a deviation in gait exists. Some of the named gait signs that we want to talk about include those named gait signs that are described in the AMA guides, such as the Antalgic Gait and the Trendelenburg Gait. And we also want to talk about some of the other types of gaits that we will encounter in the qualified medical evaluation, but that are not specifically described by name in the AMA guide. So some examples include the broad-based gait, and I'll give you several different types of examples of that. The steppage gait, the gluteus maximus lurch, and then also to illustrate a principle that we commonly encounter in the qualified medical evaluation, I want to talk about the festinating gait. And that's an example that's going to illustrate the principle that during the qualified medical evaluation, we may encounter other comorbid conditions that overlie and overlap the industrial injury. And I'm going to cite an example wherein I identified an examinee who had the development of Parkinson's syndrome over and above and on top of his industrial injury, and it was the qualified medical evaluation that was successful in diagnosing this condition for the first time and in directing the examinee toward medical treatment for this condition. Even though the medical treatment was non-industrial, it was the QME evaluation that identified the condition, and it was identified through the presence of what appeared to be a festinating gait. Okay, so let's begin with Antalgic gait and talk about each of these named gait signs. And I have a real treat for you here, because in addition to our descriptions of these gait disturbances, I also have some videotaping for you at the conclusion of this section that demonstrates each of these gait disturbances.
Okay, so let's begin with the Antalgic gait. Now, an Antalgic gait is a gait that's characterized by leaning away from pain. In fact, the word Antalgia comes from the Greek word anti-algos, which means simply away from pain. So with an Antalgic gait, we see that the examinee leans away from pain. So what would be some examples of that? For example, in the case of a right-sided lower back pain, an examinee with right-sided lower back pain, they'll be observed to lean where? They lean to the left. They lean to the left in order to get away from the pain, which is on the right. And you've probably seen examples of this before. Let me ask you, Mr. Attorney, have you ever seen a person walking seemingly crooked? It looks as though their torso is crooked. Sometimes someone will walk towards you and they look like a comma, meaning that they're leaning and their torso is curved one way, or they're walking crooked, whether it be bent forward or leaning left or leaning right. These are all examples of antalgia. And this person might think you're a genius if you were to come up to them and try to identify their problem, because in most cases you can correctly identify the problem by seeing where they're leaning. They're leaning away from the pain. The pain is on the opposite side. Okay? So as another example, in the case of a person with an ankle sprain, sprain of the lateral talofibular ligaments, that is, they would be observed to shorten the stance phase on that leg in order to get away from the pain. And we would call that a limp. You say that the person is limping. Well, this is an example of an antalgic gait. And the interesting thing about antalgic gait is that the level of the pain determines the degree of the antalgia, or the shortening of the stance phase that you will observe. And I have a video of antalgic gait coming for you shortly. The next gait is the broad-based or so-called ataxic gait. This is found in a variety of different types of conditions, including traumatic disorders that we see in the workers' compensation setting. And this is due to an impairment of the ability to coordinate the movements required for normal walking. And this can be due to impairments of either motor function or sensory function. And this is commonly seen in the cervical myelopathy cases under Chapter 15, those examinees with a spinal cord injury. They have impairments of both sensory and motor function. So imagine a person who, for example, has numb feet due to either central nervous system disorders such as cervical myelopathy, or even a peripheral nervous system disorder such as diabetic neuropathy. A person who has numb feet has impaired sensory feedback from the feet. Therefore, they have difficulty with balance, and therefore they have a need to widen the base of support. And I gave an example earlier of getting up in the middle of the night and trying to get down to the bathroom without bumping into walls on both sides of you. And I have a video of the broad base gait coming up for you shortly. The Trendelenburg Gait is specifically described in the AMA guides. And the Trendelenburg Gait was first described in the 19th century by orthopedic surgeon Friedrich Trendelenberg. He identified this particular type of gait in children with congenital dislocation of the hip. And I have two examples of Trendelenburg Gait coming up for you. One is my own interpretation or my own imitation of Trendelenburg Gait. And then also I have a live examinee who beautifully demonstrates the Trendelenburg Gait due to congenital hip dysplasia. Now, the Trendelenburg Gait, regardless of its cause, whether that be in juvenile or adult examinees, in our case in workers' comp we're talking about adult examinees, but regardless of the cause, a common feature of all examinees is that they present with weakness of the gluteus medius muscle. So this would be accompanied by positive and true objective physical examination findings, such as weakness of the gluteus medius muscle, which is one of the gluteal buttocks muscles. Now, the gluteus medius muscle is responsible for stabilizing the pelvis as the legs go through the gait cycle. So a Trendelenburg Gait manifests itself by a sudden dropping of the pelvis inferior, in other words, a downward dropping of the pelvis on the non-weight-bearing leg. So as the weight-bearing leg goes through the stance phase of gait, the pelvis on the non-weight-bearing side drops inferior, drops downward due to lack of stabilization of the gluteus medius muscle on the side of the leg in stance phase. And this is a pronounced deviation in gait, and you will notice it. And I have a video for you coming up to demonstrate the Trendelenburg Gait. Now, because of weakness of the gluteus medius muscle and a dropping of the pelvis on the non-weight-bearing side, the examinee has to compensate for this. Otherwise, they would fall over towards the non-weight-bearing side. So in order to prevent themselves from falling over, they throw their body toward the side of the leg going through stance phase. And it's a quite pronounced and awkward gait. In fact, when I was videotaping my demonstrations for you, I found it quite exhausting to do 3 passes of the Trendelenburg Gait. And I'll show you that here coming up shortly. The next gait to go over with you is the steppage gait. This is also known as the equine gait, and you've seen these types of people out in the public before. It's quite a pronounced deviation in gait, and it's quite common actually. And the interesting thing about steppage gait, well, first of all, steppage gait is due to loss of use or loss of function due to weakness of the front shin muscle, known as the anterior tibialis muscle. And the anterior tibialis muscle is responsible for lifting the ankle into what's called dorsiflexion. Now, this can be due to a direct trauma to the anterior tibialis muscle, such as a contusion, or can be due to a neurologic disorder of the spinal nerves, typically L5, or due to injury of the common peroneal nerve. And I don't know if you've ever had an injury to the common peroneal nerve, but I have. And the common peroneal nerve is interesting because, like the ulnar nerve in the arm, the so-called funny bone nerve in the arm, the funny bone nerve is very superficial and easily easily struck by bumping your elbow on objects. Well, the common peroneal nerve is very superficial as it comes around the outside of the leg just below the knee where the top of the fibula bone is. The nerve is very superficial there. And one day I struck that nerve on a bench in the gym locker room, and all of a sudden my anterior tibialis muscle went limp, and I could not control my ankle for like 15 minutes until it slowly started to come back. Well, people with steppage gait have varying degrees of disguise for the disturbance. Someone who's had steppage gait for a long period of time learns ways to circumduct their leg and learns ways to subtly and almost imperceptibly lift the hip and the knee to disguise the dysfunction at the ankle. But if you're sharp and if you're astute, you can pick it up. Because due to inability to control the ankle, there's increased hip and knee flexion in order to bring the foot high enough for the toes to clear the ground. And like I said, this can either be subtle or it can be profound. And the videotape where I demonstrate this coming up in just a minute shows the example of the more profound steppage gait. The next gait is the festinating gait. This is found in central nervous system disorders such as Parkinson's disease, all of which are characterized by near spasticity, or what's referred to as hypertonicity, overtone of the lower extremity muscles. And with a festinating gait, the examinee has difficulty in getting the gait initiated due to difficulty in moving and difficulty in coordinating the lower extremities. But once the gait gets initiated, the steps become increasingly shortened, almost as if stumbling and almost as if running by falling forward. And it appears that the examinee is falling forward, unable for the legs to catch up with the body. And a similar example of festinating gait is sometimes seen in toddlers who are just learning to walk. You know, they will take one hesitating step and then take another hesitating step and then another and another and another, and they all of a sudden they're almost running, and then they come to a quick stop as they catch their balance and get their wits and get their legs back under them again, and then the cycle repeats. And this is the same type of a gait that we see with the festinating gait. Then finally, the gluteus maximus lurch is an interesting gait disturbance. It's not as frequently seen as the Trendelenburg gait or the steppage gait, but it is out there because it is also caused by injury to any of the spinal nerve roots, L5, S1, or S2, or also due to an injury to a local peripheral nerve known as the inferior gluteal nerve, which can often be damaged with hip replacement surgery. So injury to the inferior gluteal nerve or any of those nerve roots causes a weakness of the gluteus maximus muscle. And you're all familiar with the gluteus maximus muscle. So with weakness of the gluteus maximus muscle, we have inability for the hip to extend. The gluteus maximus is a hip extensor muscle. So lack of normal hip extension strength of the gluteus maximus requires compensatory extension of the torso over the hip. Otherwise, the examinee would simply double over and fall forward at the hip during the heel strike phase of gait due to lack of stabilization through the gluteus maximus muscle. And I have a demonstration for you here. Now what's interesting is if we think about the Trendelenburg Gait and we compare it with the gluteus maximus lurch, both of them include compensatory movements of the torso over the base of support, and the base of support is the hip socket. But the Trendelenberg involves a lateral or sidewards compensation, whereas the gluteus maximus lurch is characterized by a posterior or backwards compensation. So the Trendelenberg gait is very well demonstrated and very well visualized when viewing the examinee from either the front or the back, whereas the gluteus maximus lurch is very well demonstrated and best visualized when viewing the examinee from the side. And this illustrates the principle of the necessity of observing the examinee from multiple directions. Okay, and so I'll show you a videotape of each of those gait disturbances in just a moment. There are other types of named gait signs that are more esoteric and not as commonly seen, but that you may run across, including the athetotic gait, the Charcot's gait, frontal gait, hysteric gait, and dystrophic gait. Probably the most common of which that we would see in the workers' compensation setting would be the Charcot's gait, which is due to progressive and chronic joint damage in the lower extremities, such as in the toes and in the foot. Okay, so those are some of the named gait signs.
Okay, so that's a lot of material. Let's bring today's program to a close and just conclude with a couple of remarks that will serve as an introduction to next week's presentation on the formal gait analysis. You might be wondering to yourself, what's a reasonable place to begin a gait analysis? Or you might be wondering to yourself, well, how do I start to do an analysis of gait if I've never done it before? And what are the kind of things that I'm going to be looking at on an introductory level to begin to become comfortable with doing a formal gait analysis on each and every appropriate case? So let's just go over a couple of key observations that you can start to focus in on to become familiar with analyzing gait. And one of the places where we can begin to look is with the stride. And we can look at the sequence of the stride, the length of the stride, and the time or the timing of the stride. So for example, we can look at the events, the sequence of events between successive heel strikes of the same foot. And pretty much that's how gait itself is described and gait is analyzed. And that's how we began today's presentation, by looking at the sequence of events between successive heel strikes of the right foot. We use the right foot today as an example when we reviewed the gait cycle. So you can look at all the things that take place between two consecutive heel strikes of the right foot. And of course, those events should be smooth, those events should be unlabored, those events should be effortless, basically, in order to constitute normal stride. We can look at the length of the stride. The length of the stride is the distance between two successive heel strikes of the same foot. Again, talking about the right foot, this would average about 57 inches. And of course, the stride comparing the right lower extremity and the stride comparing the left lower extremity should both have roughly the same length. They should average 57 inches. And many times, depending upon the lower extremity pathology, the stride length of one lower extremity will be normal, and the other lower extremity will be shortened, have a shortened stride length. We can also look at the stride timing and analyze the time for a full gait cycle. Well, what about the step? The step is interesting. There's many components of the step that we can focus our attention on in analyzing the gait. With regards to the step, we have some of the same components as we have with the stride. We have the step sequence, we have the step length, and we have the step time. So, for example, with the step sequence, we can start to focus our attention on the sequence of events between heel strikes of opposite feet. Now looking at opposite feet rather than looking at the same feet. We can look at the step length, which is the distance between successive heel strikes of two different feet. The average is 28 inches, and that makes sense because when you consider putting two steps together, that gives us one stride, and the average length of the stride is 57 inches. 28 times 2 is roughly 56 or 57 inches, and so that makes sense. And when we compare the left lower extremity step length to the right lower extremity step length, they should be roughly the same. Also, we can look at the timing for the completion of heel strike of right foot to the heel strike of the left foot, the so-called step timing. Also, there's several other generalized observations that we can make of the gait. And just to finish off the step and the components of the step, one of the components of the step that we're going to want to observe is the step width. And we've talked about several different pathologic conditions or types of gait disturbances that involve an increasing width of the step. Now, the step width is the lateral distance between the heel centers, in other words, the center of the heel, of two consecutive foot contacts. And so if we were to draw two lines parallel to the foot, as the left foot lands on the ground and goes through the gait cycle, and then as the right foot lands on the ground and goes through the gait cycle, if we were to draw parallel lines down the long axis of the footprint made by the left and right lower extremities, we would see that the distance between those parallel lines is roughly 3 to 4 inches. And pathologic conditions can result in a widening of the step width, and we refer to that as a broadening of the base of support. And we've already alluded to several different types of named gait signs that result in a broadening of the base of support. So step width is going to be an important observation. The cadence of gait involves an observation of the step rate, which is the number of steps per minute, and that averages roughly between 90 and 100 steps per minute. And many times you'll observe in your injured workers that they have a markedly reduced step rate. They walk very slowly, they walk very deliberately, and the number of steps per minute is at 60 steps per minute and even below. So this is an important observation as well. And then finally, walking speed is closely related to step cadence. Walking speed in an average person walking at an average pace is roughly 3 miles per hour. And you'll want to observe the speed at which your examinee is able to move. If they're moving roughly 3 miles per hour or greater, and without significant labor and without significant effort, and without significant deviations in either the swing or the stance phases of gait, it's probably likely that there's no disturbance of the normal gait pattern. Okay, doctors, so let's bring today's program to a conclusion. I want you to stay tuned for next week's program, where we go over the formal gait analysis and the actual procedure involved with taking your examinee outdoors and putting them through some physical examination procedure for the substantiation of your objective findings for a disturbance of station and gait, or a derangement of gait, as those are described in both chapters 13 and chapter 17. So to review today's topics, we went into the phases of the normal gait cycle, including some extended discussion of the stance phase and the swing phases of gait. And we compared and contrasted pathologic gait with normal gait by looking at the stance and swing phases of gait from both the lateral view and from the anterior view. And then I provided for you several examples of named gait signs and named gait disturbances with my homemade videotaping of Antalgic Gait and Trendelenburg Gait and the gluteus maximus lurch and other gait disturbances that we commonly encounter with our examinees. So I look forward to being with you next week when we go over part 3 of our 4-part series. We get into the formal gait analysis, and I know that will be an invaluable presentation for you. As I said at the beginning of this presentation today, this is material that you cannot find discussed anywhere else. So for today, this is Dr. Perry Carpenter. I want to thank you for joining me on today's video, and I look forward to being with you on next week's video. And for now, I'm wishing you best of success in your career as a qualified medical evaluator.